In this episode of Crit Care Bites, we'll be discussing about cardiac output monitoring. This will be the content that will be covered in today's discussion. So to provide a bit of a background, cardiac output monitoring devices derive cardiac output using different technologies and also produce other hemodynamic parameters that can be used to guide hemodynamic management. The different devices differ in terms of the parameter outputs, how these outputs are derived, their degrees of invasiveness, and the limitations. Most critically ill patients are monitored with an arterial line. Addition of a central line allows for additional parameters like central venous oximetry and the CO2 gap that is discussed in the shock lecture series. Echocardiography is also a useful adjunct, but is non-continuous and operator dependent. In patients with cardiogenic or mixed shock, or those who require high doses of vasoactive medication or do not respond to initial treatment, more invasive monitoring may be considered to provide additional information to guide management. Importantly, the values produced from these monitors should be taken in context of the patient's clinical condition alongside other data points like the lactate, central venous oximetry, CO2 gap, as well as end organ function. Indications and use cases of cardiac output monitors include the following. Firstly, assessment of fluid responsiveness, where changes in stroke volume or certain measures like stroke volume variation can be used to assess fluid responsiveness. These devices also help with diagnosing the etiology of shock and assessing the relative contributions of the different concomitant etiologies that may be present based on indices like the cardiac index, systemic vascular resistance, as well as preload indices. Phenotyping in cardiogenic shock can be done using methods like a PA catheterization. They also permit guidance and assessment of treatment response and can also help with the assessment of fluid status or fluid tolerance. So these are some of the monitoring devices that will be discussed today, classified based on the degrees of invasiveness. The bolded modalities are those that we'll be focusing on because of their availability of use as well as the robustness of evidence in a critically ill patient context. Some of the less non-invasive modalities will be briefly discussed just for completeness of today's discussion. Focusing on the modalities that are more commonly used in our ICUs, namely arterial catheter, pulse contour analysis, commonly referred to as the flow track, transpulmonary thermodilution, and pulmonary artery catheterization. I think it is useful to classify the different parameters into the insights that they provide to form a hemodynamic picture. So this can be thought of in terms of preload contractility, afterload, global cardiac output, as well as measures of fluid responsiveness and tolerance. Secondly, it is also important to note that which parameters are actually measured as seen by those bolded, in contrast to those that are derived from equations. These will be explained in detail as we go through the different modalities. So this slide presents some of the normal values of different parameters. I've intentionally parenthesized normal with inverted commas because these values must be taken into context of the patient's condition. For example, a patient with a chronically low ejection fraction may have a low cardiac index and a high systemic vascular resistance index at baseline, but has actually developed adaptive mechanisms to compensate, and this patient actually may not necessarily require hemodynamic augmentation or manipulation. Conversely, a patient with an ongoing acute myocardial infarction going into cardiogenic shock with a similar hemodynamic picture actually requires urgent resuscitation and hemodynamic support. As such, these values serve only as a ballpark reference to guide overall management, but importantly has to be contextualized to the patient's overall clinical state. So starting with pulse contour analysis or pulse wave analysis, these methods derive stroke volume from the area under the curve of the systolic portion of the arterial waveform as shown in the diagram here on the right. So this is the stroke volume derivation from the systolic upstroke. So this is based on the principle of ventricular arterial coupling where a pressure signal is extrapolated to a volume based on internal or external calibration, which will be discussed further. The most familiar use case of pulse contour analysis is probably via an arterial line, commonly referred to by the Edwards Life Sciences product name FlowTrack. In this example, the derivation of stroke volume from pulse wave analysis is based off proprietary algorithms from patient-specific anthropometric and demographic data, a process termed as internal calibration. Pulse contour analysis can be used in other ways as well, using non-invasive technologies like the volume clamp and radial artery applanation tonometry to provide an arterial waveform which is similarly analyzed, and can also be used alongside transpulmonary thermodilution, where the stroke volume derivation can be externally calibrated against a more robust measure. These will be discussed further in the subsequent slides. The image on the left is a screen of how a typical pulse contour analysis module looks like. Quite a lot of information is showcased, hence it is important to have a systematic approach to using the values seen. The table on the right comes from the earlier summary table and helps us to put into context some of these different values. As previously mentioned, stroke volume is the most directly derived variable via pulse contour analysis, from which cardiac output can be calculated based on the formula heart rate times stroke volume. From cardiac output and stroke volume, their respective index values of cardiac index and stroke volume index are calculated by dividing by body surface area, and stroke volume variation, as seen here, is measured as the difference between the maximum and minimum stroke volume divided by the mean stroke volume. Stroke volume variation provides insights into fluid responsiveness if appropriate conditions are met. Next, in order to derive systemic vascular resistance value, the mean arterial pressure and central venous pressure is needed, as seen from the equation here, where it is taken that SVR equals to mean arterial pressure minus the central venous pressure divided by cardiac output multiplied by a conversion factor of 80. Hence, a CVP value can either be obtained via a central venous catheter measurement or can potentially be estimated based on IVC ultrasound as shown in this table here, where gross estimates can be derived from such. With these values, impact of fluid therapy, vasotherapy, inotropic therapy can hence be monitored. The main benefits of pulse contour analysis are that it's automated, provides continuous beat-by-beat measurements, and is not technique or operator dependent. These properties are useful for trending purposes in real time when compared to some devices that provide more episodic measurements. It is also relatively minimally invasive, even when used with an arterial catheter. However, there are significant limitations to be aware of. Firstly, its reliability is less well established in the ICU population, with observational studies demonstrating fairly high margins of error. This is likely related to internal calibration being based off fairly healthy patient populations and changes in arterial ventricular coherence in patients who require high vasopressor support. Pulse contour analysis is also subject to drift over time, especially when there is no external calibration. Moreover, when using measures like stroke volume variation, conditions of respirophasic variation need to be met in order for it to be a reliable measure of fluid responsiveness. As such, perhaps the use of pulse contour analysis should be confined to patients with lower degrees of disease severity, with focus on trends rather than the absolute values. Next, we'll discuss about transpulmonary thermodilution. Transpulmonary thermodilution requires, or rather involves, the administration of a cold injectate via an internal jugular central line and detection of temperature change through a femoral arterial catheter to determine cardiac output. A thermodilution curve, as seen here, allows for calculation of cardiac output using the Stewart-Hamilton equation, where cardiac output is inversely related to the area under the thermodilution curve. This technology can be paired with pulse contour analysis, allowing intermittent external calibration with cardiac output derived from the transpulmonary thermodilution, and also facilitating real-time monitoring in between these thermodilution events. Additionally, transpulmonary thermodilution also allows for derivation of intrathoracic volumes, which provide additional hemodynamic insight. The diagram shown here on the right explains how these different volumes are obtained. The two directly derived volumes are the intrathoracic thermal volume, which is derived from the mean transit time, and the pulmonary thermal volume, which is derived from the downslope time of the transpulmonary thermodilution curve. Thereafter, global end diastolic volume is calculated as the difference between ITTV as well as PTV. Intrathoracic blood volume is taken as 1.25 multiplied by the global end diastolic volume. And finally, the extravascular lung water is the subtracted difference between the intrathoracic thermal volume and the intrathoracic blood volume. These are actually demonstrated here using the diagram seen, where we can see how the different subtractions and manipulations of different values provide the respective calculated values that have been discussed. In summary, the global end diastolic volume provides a suggestion of preload, and extravascular lung water provides a quantitative measure of pulmonary edema, which can be used to assess fluid tolerance and need for deresuscitation. And interestingly, these volumetric indices have been found to be rather accurate when corroborated against autopsy studies. This table summarizes the output of transpulmonary thermodilution as well as the clinical significance of each value. The additional measures of extravascular lung water index and the pulmonary vascular permeability index helps with characterizing the etiology of lung edema and also guides with fluid therapy. The other measures of cardiac index and systemic vascular resistance are similar to what was previously discussed in pulse contour analysis. Some caveats of transpulmonary thermodilution include the following. Ideally, an internal jugular CVC should be used. If a femoral CVC is used, it should be on the different side as the arterial catheter, and even if so, only the cardiac output measurements are reliable, and instead the thoracic volume measurements are not valid in this instance. It can be used in continuous renal replacement therapy but not with ECMO, and should be avoided if there are concerns about femoral arterial vasculature integrity. Furthermore, in patients with very low cardiac output states, the derived cardiac output values may not be as accurate. So when should transpulmonary thermodilution be used? I find it useful in patients with mixed shock with concomitant respiratory compromise, be it from ARDS or cardiogenic pulmonary edema. It provides a fairly robust measure of cardiac output where thermodilution is actually generally considered a gold standard and can actually be paired with pulse contour analysis to guide fluid therapy and facilitate continuous hemodynamic monitoring. And it also provides volumetric indices that can guide fluid therapy. It is actually also all not that invasive, given that critically ill patients require a CVC and arterial line anyway in most instances. However, of note, this arterial line is usually placed in the femoral artery rather than the radial artery if this technology is being employed. Its main limitations, however, is that it does not differentiate between right and left-sided pathologies in the heart and is hence less able to phenotype patients with complex cardiogenic shock. So this provides a good segue into discussing about pulmonary artery catheters, which are considered the gold standard for cardiac output monitoring because of an accurate measurement method, namely thermodilution, and the provision of right and left-sided heart indices. The catheter is inserted via a large vein into the right atrium, right ventricle, pulmonary artery, throughout which waveforms are observed and pressure readings are measured as shown in the diagram here on the right. The catheter is intermittently wedged with an occlusion balloon in a tapering branch of the pulmonary artery, and a wedge pressure is obtained as seen here. Thermodilution is performed for cardiac output measurement, similarly to how it's done for transpulmonary thermodilution. The main drawbacks of this method is its relative invasiveness, the requirement for technical and interpretational expertise, And while there is a lack of RCT data to show that the use of PA catheters improve clinical outcomes, it is certainly useful in the context of diagnosing, phenotyping, monitoring, and guiding treatment in patients with cardiogenic shock, especially in severe cardiogenic shock or when there is a significant RV component, or in patients with pulmonary hypertension. The measurements obtained from a PA catheter include different pressures obtained during insertion as seen here with the normal values cited, cardiac output which is measured using pulmonary thermodilution, and the pulmonary capillary wedge pressure that is obtained during the wedging process. The clinical significance of these readings are summarized below, where a framework of both contractility, preload, afterload, as well as left versus right-sided considerations can be used. The diagram on the right shows how a PA catheter looks like, with the different ports serving different functions. The basic components include proximal injection port that sits in the right atrium, and it's also where cold saline bolus is given during thermodilution. Distal injection port, which allows for sampling of SVO2, a balloon inflation valve to inflate the balloon during wedging, and a thermistor connector that detects temperature change. This table summarizes the hemodynamic profile based on the different indices obtained from a PA catheter. Of note, PA catheterization is not usually required in straightforward causes of hypovolemic or distributive shock, shown in the first two lines. The CVP as well as the pulmonary capillary wedge pressure are useful indices to differentiate between right and left-sided cardiac dysfunction. Two important parameters are cardiac power output, and the pulmonary artery pulsatility index. Cardiac power output, or CPO, takes into account both blood pressure and cardiac output, and has been shown to be a strong prognostic indicator in cardiogenic shock. The pulmonary artery pulsatility index is an indicator of RV failure, and it's numerically defined by the difference between the systolic and diastolic pulmonary pressures divided by right atrial pressure, where values of less than 1.5 is associated with RV failure, and the degree of depression of this number also correlates with severity of RV failure. So the next few slides will discuss some of the less invasive monitoring modalities. While they may be attractive for this reason, their accuracy in critically ill patients is yet to be established. Most of these devices are being explored in a perioperative emergency department and inpatient ward setting amongst patients with perhaps slightly higher illness acuity that require closer monitoring. Its robustness and reliability in the ICU context has not been established. Hence, I'll just briefly cover some of these modalities. So, radial artery applanation tonometry, as seen here, as well as the volume clamp method, are different technologies to non-invasively produce arterial waveforms that can be subject to pulse contour analysis. The former uses electrical mechanical sensors over the radial artery pulse, while the latter uses a pressurized clamp around a finger to maintain a constant blood volume, wherein the required pressure changes to maintain this volume can be used to construct an arterial waveform. Similar principles of pulse contour analysis then apply, with probably the added element of reduced reliability of these constructed waveforms when compared to invasive arterial catheter measurements. Hence, the limitations of pulse contour analysis apply, and there is the additional element of maybe a less reliable input value. Bioreactance technology has gained quite a bit of traction in recent times. It makes use of voltage phase shifts over a cardiac cycle because of pulsatile changes in intrathoracic blood volume to determine cardiac output. Fluid responsiveness can be determined by evaluating changes in stroke volume following a passive leg raise of fluid bolus, but importantly, conditions that affect the intrathoracic volume, like pleural effusions, pulmonary edema, or things that may affect electrical signals like pacemakers, electrical interference and movements are possible caveats when utilizing such technology. So this is a module interface of the Starling Cheetah device that makes use of bioreactance technology. And as seen here, values like the cardiac output, stroke volume, heart rate, and this thing called the total peripheral resistance index that kind of correlates with systemic vascular resistance index can be derived from these values. And as seen here, what this device also actually does is that it constructs a Starling curve seen at the bottom here based on multiple cardiac output or stroke volume measurements and response to passive leg raise as seen by the PLR protocol or fluid bolus can be measured accordingly. The last device we'll discuss is an esophageal Doppler, which we don't use very much locally. It involves placement of a Doppler probe into the mid-thoracic esophagus and is oriented posteriorly towards the descending aorta. Continuous wave Doppler is transmitted from the probe and the velocity time waveform is plotted based on reflected waves from red blood cells in the aorta, from which different parameters can be derived. Limitations include the following: that firstly, stroke volume is derived based on a nomogram rather than actually measured. The aortic cross-sectional area is also not actually measured. There's an assumption of a fixed distribution of cardiac output to the descending aorta. It is positionally dependent, and there's also assumption of laminar flow. The three key parameters of stroke distance, flow time corrected, and peak velocity corresponds to markers of stroke volume, vascular resistance, and ventricular contractility. And summarized in this slide are some of the normal values. In summary, in patients with simple shock states like in hypovolemic or vasodilatory shock like in septic shock, invasive blood pressure monitoring using an arterial catheter paired alongside episodic ultrasound and biochemical markers like lactate, urine output, and clinical parameters like capillary refill time usually suffice in guiding management in these patients. In patients who are a bit more complex, where there might be a concomitant element of cardiogenic shock, consideration of monitoring central venous oximetry, CO2 gap, possibly with the use of arterial line pulse contour analysis can be considered. However, one should be aware of the limitations that have been discussed. In patients who are in severe mixed shock or cardiogenic shock, more invasive monitoring devices like transpulmonary thermodilution and pulmonary artery catheterization should be considered. In patients with concomitant ARDS, transpulmonary thermodilution provides volumetric indices that are useful to guide fluid management. And in patients with severe cardiogenic shock, especially when there's a significant RV component, or when there are plans to use mechanical circulatory support where phenotyping is imperative, a PA catheter is usually considered the gold standard. Finally, it is important to remember that while these devices are useful and provide additional data points in monitoring and management of patients, they must always be considered and interpreted in the context of the patient's overall clinical situation, as well as other clinical and biochemical parameters that are available. Thank you.